Good morning, good afternoon, and good evening to all the trainees who have joined our YouTube channel discussing topics for urology exam preparation. Today, we are going to conduct a mock viva on the technology topics in urology. We have our trainees. Thank you for joining us. Can we start with the first trainee? Someone is
I
okay.
don't know who is trainee one. Can you unmute, please? Thanks.
Oh, sorry, I was muted.
No worries. So your time starts now. You are doing a laser lithotripsy for 10 millimeter upper ureteric stone using a semi-rigid ureteroscope. During the procedure, one of the medical student attends the theater and she is very much interested to know how this laser works. How are you going to explain her?
So I'll explain to her that laser, or as it is an abbreviation for light amplification by stimulated emission of radiation, works by the principle of by it having a lasing medium, which gets pumped by an energy source, and this is inside a chamber. The laser which I'm using for this procedure would be holmium yak or holmium yttrium aluminum garnet. That is the medium, and that gets pumped. So when it gets pumped, the energy from the lower orbit goes, the electron from the lower orbit goes to the higher orbit. And then when it drops down back to the lower orbit, it releases photons. And this process is repeated throughout the medium, leading to release of these photons. Now, this lasing medium is present between two reflecting mirrors. And as the photons reflect between these two mirrors, there's an aperture at the end of one of them, which leads to these photons coming out at high energy. Now, laser has three important characteristics. It's monochromatic, which means all of them have the same wavelength and hence the same color. In this case, it would be 2140 nanometers. It is coherent and it is collimated. So this means that coherent means that it's in phase. It means that it's in phase, which means that all of these photons are in the same phase. And finally, monocollimated means they're parallel to each other. So this leads to a single beam of light of the same color. That is the principle of laser. And at the end of the tip where the laser comes out, it can act by different mechanisms. Now, this is holmium yak, and it is absorbed by water. So what that means is that it leads to creation of a bubble at the end of the laser fiber, which leads to a thermal effect at the stone and mechanical disruption of the stone.
Okay. What do you mean by coherent? Can you explain further?
So coherent means that all of the light that comes out are parallel to each other. All of the light rays are parallel to each other.
Okay. What is the importance of being coherent? What is the advantage of it?
Right. So I would like to change my answer. I'm sorry about that. Coherent means that all of them are in phase with all the fibers are in the same phase. So that means that basically light acts as a dual. It acts as a particle and a wave as well. So if you look at the wave characters, it will have a trough and it will have a high and a low. So at one point of time, all of the waves will either have a trough or it will be at a high amplitude. So this way, they don't cancel each other out, and that is what coherent means.
Okay. Now you're using this laser fiber to fragment the stones. What are all the settings available in your laser machine and how it influences the stone particles produced?
So there are three main settings that are present, and we can only alter two of them. There's energy, frequency, and the pulsing of the laser. Pulsing means but pulsing that cannot be altered in most of the lasers. We can only alter the energy and the frequency. Most commonly, we start with 5 millijoules and 5 hertz. So what this means is that 500 millijoules and 5 hertz. So what this means is at this setting, we are starting with a low energy and slightly low frequency. We are targeting to actually break the stone into fragments. If we increase the frequency, then we're going to expect dusting of the stones. We will see we will see smaller fragments, and that will lead to dust formation, and that will also help in clearing the stone. However, initially, I prefer to increase the energy gradually, depending on the consistency of the stone, and try to break them in fragments and get all of these fragments out. And only at the end of the procedure, for some very tiny fragments, would I use dusting by keeping the energy low and increasing the frequency to around 12 hertz.
Okay, so which is the main part influences whether the stone is getting fragmented or dusted of the three which you said?
It's the frequency.
Okay, and what is the pulse energy?
So pulse energy means that a laser can either have a continuous output or a pulsed output. So when the pulse duration is decreased, then the energy given out more energy is given out in a very short period of time. So that is the main difference between a continuous output laser and a pulsed output laser.
Okay, so in your case, is there any way you can change the pulse duration?
No, in our machines, we can't change the pulse duration.
In some machines, is it possible? Maybe higher end machines?
Yes, it is possible to change, but in most machines in our setting, it is not. This facility is not available.
Is there any advantage if you have the ability to change the pulse duration?
Yes, if we shorten the pulse duration, then we'll be able to deliver more energy in a shorter period of time.
Okay, good. And what other lasers which can be used for stones? Do you aware of any other lasers?
Yes, nowadays smaller fibers are available. For example, the TFL fiber or the thulium fiber laser. The other fiber that we can use is the thulium YAG laser. And for stones, we can also use diode lasers, but they're not very popular for I've never seen them being used.
So any advantage with the newer fibers?
The fiber is smaller, so we can it'll help in further miniaturization of the process. So it can be used with smaller it'll allow better maneuverability and better irrigation through a flexible uretroscope, and it'll allow better stone clearance.
So will the settings change for thulium fiber laser?
Usually, as the fiber grows smaller, we need to use lower energy, and then we might have to use. Then we'll have to use higher frequency.
And what is the advantage of this higher frequency?
With higher frequency, we can achieve dusting of the stone.
Okay. What is the disadvantage of the newer fibers like thulium fiber laser?
First of all, they're not widely available, and hence they're still very expensive. And secondly, because they're smaller, they're more friable and can break easily. So the cost will increase. And we can't use high energy, so we'll have to rely more on dusting rather than fragmentation.
Okay. Is there any other significant side effect during the procedure noted in thulium fiber laser compared to holmium?
With thulium, there is production of a distinct charring effect on the stone, but that is all I'm aware of.
Okay. Is it possible to use these lasers in tissues other than stones?
Yes. So holmium YAG laser is very commonly used for holmium enucleation of the prostate. Other lasers are also used for tissue. For instance, holmium laser is used for ablation of TCCs of the ureter or the renal pelvis. Photovaporization of the prostate can be done by using green light laser or helium titanyl phosphate laser. Lithium borate laser can also be used for this indication. Additionally, neodymium laser has been used for ablation of soft tissue as well. And en bloc resection can also be done by holmium laser of bladder tumors.
Okay, so what is the mechanism of the tissue reactions? Is there any difference compared to stones?
So at the stone, it would. No, I'm not sure about that. Sorry.
Okay. Is there any newer technology available in the holmium laser you are aware of?
Yes, there is something called as Moses 2 technology, which is available, which uses double plasma, double bubble effect. So basically, it creates one bubble, and then that creates another bubble leading to destruction of the stone. This way, we can actually stay a bit away from the stone and still manage to break the stone.
So, what may be the advantage of Moses compared to the non-Moses holmium?
It allows better visualization and better stone clearance as well.
Okay. And if given the choice to you, which laser machine you will buy for your department for both prostate and stones?
So if I have enough funds, I'll prefer a high-powered holmium laser because then I can use it for prostate procedures as well as stone. But if I don't have enough funds, I'll still buy a 50-watt holmium laser because that can also be used for HOLIP as well as stone and end block resection as well.
Okay, very good. Time's up. And yeah, good performance. How do you think you did?
I did okay. I interchanged coherent and collimated initially, but I think I said correctly at the end. I'm not 100% sure. I'll have to check.
Yeah, I mean, you made the point clear. I mean, the overall the answers are correct, but it can be more sleek. Maybe that's the correct terminology to say because of multiple practices. This comes only by practice. The knowledge, the difference between just having the knowledge and practice is the how we are going to bring out what we have read without wasting any time, using only the small amount of words because time is very precious in the FRCS exams. We need to prove our point in the 10 minutes. So without wasting any time, how we can communicate in a crisp manner. I'm happy with your definitions of coherent. Maybe at the time you can keep a paper, there will be paper and pencil in front of you, so you can even draw to show that
draw it and show, yes,
the waves are parallel to each other, and since they are in the peak and trough in the same time, it gives a very high energy. And as you said, it won't cancel each other since they are parallel to each other. And other terminologies you can bring in is total internal reflection. So the main idea in all the 8 tables is for a question you should have a keyword of 5 or 6 in your mind. If you just say what is laser, and if you say, like for example, the question is what is laser, and if you say total internal reflection, a medium, a collimation, and a coherent, monochromatic, if you just say only the keywords, it doesn't sound good. Okay, all you are doing is you are covering all the keywords with appropriate verb and full sentences so that it makes sense. My feeling is there is a good possibility the examiners will have answers only in the form of a keywords, and if you are able to tick all the keywords, that gives very high marks. Not necessarily you need to cover all the keywords. There will be always a touch more in the examiner's key, but you should be able to bring in as much of keywords as possible. That's more important. In one place I differ from you is the settings for the dusting and fragmentation. So the main principle which differentiates dusting and fragmentation is the energy setting. Okay, you have to keep, if you keep very low energy, you can easily understand this. There is a stone, you are giving very low energy to its surface. The low energy will take only a small chip of it away. Okay, if you give a large energy, the energy can even break the whole stone into 2 stones. Okay, so that's how the low energy produces dusting, while high energy produces fragmenting. As far as the frequency is concerned, since all the machines have fixed watt, like for example 30 watt, 50 watt, 100 watt, if I use low energy, there is more gap available for me to play with the frequency, and I can increase the frequency. So that's why lot of us during the dusting tend to have high frequency because you have room to play. In case of fragmenting, since you are already using lot of energy, you don't have much room to play in the frequency. The role of frequency is only to speed up your procedure. That's it. It has nothing to do with the fragmentation or dusting. If you do dusting with low energy and low frequency, you will take time. It creates very nice dust, but it does in a very, very slow manner. Already by dusting, it's a slow process. and you want to really balance it out by increasing the frequency so that you are finishing the stone dusting in a quicker time. The advantage of the thulium fiber laser is it can give us the opportunity to increase the frequency even up to 2000 hertz, while normally in holmium we are going only up to 50 to 70 hertz maximum, depending upon the machine what you use. And since it produces so much of frequency, we can keep the energy to a very low level like 0.1 or 0.05, and which really vaporizes the surface of the stone. And if properly done with proper irrigation, and it creates a very nice powdery dusting. You don't have to use a basket. You can just use some irrigation to clear it off, and then put a stent or even a ureteric catheter, or even without anything, so that the patient can pass out the fragments or dust like, so that it won't cause any problems of Steinstrasse or anything in the next few 24 to 48 hours. The main disadvantage of thulium fiber laser is, as the frequency is high, it happens even with holmium. If you use very high frequency like 50 hertz, as the frequency is high, it produces lot of heat and it produces fiber burnout, and the producing of charring effect in the stone doesn't matter. If the stone gets charred, as long as the stone is getting broken, everything is going to be passed out. So we don't want to preserve the structure of the stone. The problem is the heat produced can cause concomitant injury to the ureteric wall, especially if the stone is like an impacted stone, if the ureteric mucosa is already breached, and then because of the heat, absence of mucosa, that tissue will get scarred, and patient can present later with ureteric stricture that is much more higher in the thulium fiber laser because of the high frequency. So you need to use good amount of irrigation. The normal saline what you use should not be warm. It should be room temperature, and because already the fiber will heat up the normal saline. Tissue interaction, your explanations are good. The main role of holmium for tissue interaction in anatomic endoscopic enucleation of the prostate. See, again, I'm bringing down the terminology. Okay, so bring in as much of keyword terminologies. That's very important. In anatomic endoscopic enucleation of prostate, the key use is only hemostasis. With the help of the cystoscopy beak itself, you will be creating a plane. The physically you will be creating a plane, and if there is any obvious vessels or bleeder, you will be using for hemostasis. So that's the main advantage. Of course, you use it for cutting here and there, but if a surgeon is using holmium laser as the main source for cutting the tissue plane, he will be never in the correct plane. If you cut, you will enter into wrong plane. Only if you separate anatomically, it will create a plane, and you use holmium to create a hemostasis. That's why when you use thulium for anatomic endoscopic enucleation of the prostate, the outcome is slightly lesser, because the thulium hemostasis is not as good as holmium hemostasis. It's the same thing with bipolar. With the bipolar, you can do the AEEP. The problem is the hemostasis mechanism of bipolar is not as good as holmium. So holmium creates very nice sharp hemostasis. So end of the enucleation, your bed looks clean compared to little bit of cautery effects here and there. Okay.
Got it.
Good.
Thank you.
That's well done. Can we start the next scenario?
Mr. Dhanasekaran, can I ask regarding the pulse width? Because what I know is if you increase the pulse width, the retropulsion comes down. Is it right? Or is there any other mechanism is there any other way that pulse width helps us?
Yeah, that's another thing I wish to give a feedback. Thanks for bringing in. So pulse width is adjustable in 120 watts holmium machine. So don't say that it is not adjustable for everyone. Of course, it is not adjustable for 30 watt and 50 watt, but 120 watts it is adjustable. There are only two settings. Yeah, there are only two settings: long pulse width and short pulse width. So if you have long pulse width, instead of the pulse going into a very high peak and coming down sharply, it stays for longer, and so the peak will be low, but the pulse will be of longer length. So that gives us a better distribution of the energy within that single pulse, and it protects from retropulsion. So when you're doing dusting, Even you can use it for fragmenting also. If you use a long pulse width, it doesn't push the stone away, especially in the early stage. Then once the stones are nicely fragmented, it doesn't really matter. So long pulse width is one of the commonest thing used for dusting as a main purpose and fragmenting as a second purpose. There are only two sittings: short pulse and long pulse.
Good. Yeah. Thanks, Mustache.
Okay, guys, can we go for the next scenario?
Yeah, that's great. Thank you. I'm ready.
Okay, your time starts now. You have a prostate cancer patient presented with PSA of 234, and obviously it's a metastatic prostate cancer. How will you evaluate the bone metastasis of this patient?
So in my practice, we do bone scan with technetium methylene diphosphonate, technetium MDP, to assess for the bone metastasis.
Okay, how it works?
Technetium MDP works with the principle of increased hydroxyapatite crystal deposition in neo bone formation. So the technetium is injected intravenously at 600 megabecquerels, and there are three phases for that. The initial, it is called as a flow phase, and there is a blood phase, and there is a delayed phase. So we take the scans with the gamma camera in the delayed phase, which is 2 to 4 hours afterwards. The technetium MDP will be taken up by the new osteoblastic neobone formation hydroxyapatite crystals, and that it will form as hot spots in the gamma camera, and that can be picked up by the gamma camera. So the increased uptake areas are considered to be metastatic deposits. However, it can give false positive hotspots when there is history of any trauma, any metabolic bone disease, or a history of Page's disease. That's why we had to give the history in the request form regarding any of these factors present before requesting for the bone scan.
Is there any other way you can differentiate whether it's a fracture or metastasis? Any techniques available?
Sorry, I'm not sure about that.
Okay. A patient is going for bone scan, and patient asks the doctor how I need to prepare myself. What advice you will give?
So I'll tell him that the bone scan will happen in the nuclear medicine suite. He has to be there for 4 to 5 hours time. He has to be well hydrated, and the scan is done from like a whole body from top down, and it will be like in a supine position. In a whole body scan, the camera will be either on the front or on the back, and there are now dual head cameras available which can scan both anterior and posterior at the same time. If we are adding spectone to it, then it is like the gamma camera going around the patient to create a three-dimensional type of image. And he should not wear any metallic objects which can interfere with the gamma camera acquisition. And he has to be there in the nuclear medicine suite for at least 4 hours.
Okay, he's 79-year-old. You are a bit worried about his osteoporosis. What you can do to evaluate his osteoporosis?
Yeah, so the EAU recommends doing a dual X-ray absorptiometry. It's called as DEXA. This is a process by which we can assess the mineral content of the bone compared to the soft tissue. The DEXA works by the principle of delivering low energy X-rays, but with two different peaks. So, for example, it can be directed at different areas of the body, like hip, wrist, and ankles. And these two low energy X-rays are perpendicular to each other. And when they hit the bone or the soft tissue, we can there's a process called as differentiation, where we can calculate how much is the mineral content, and that is compared to a T-score, either a T-score or a Z-score. For this gentleman, because he's 79, what we use is a T-score, and T-score is a WHO created standard deviation score. What T-score is the extrapolation of age-matched cohorts, and a T-score is derived with certain numbers. A T-score of more than -1 is considered to be normal. between minus 2.5 and 1, it is considered as osteoporosis, and less than minus 2.5 is considered as, I had to take it back. Between minus 2.5 and minus 1 is osteopenia, and less than minus 2.5 is osteoporosis. However, for younger children and premenopausal women, we do something called as a Z score, which is matched for age, gender, ethnicity. So this is a difference in the between the Z score and T score. So this gentleman can have the DEXA scan and see what his T score is.
How the scoring works in Z score?
That score the variables. So it's again in the a chart with a standard deviation. We use multiple variables like age, gender, ethnicity, and a score is produced, which is similar like the T score. But the standard deviation is calculated by different variables.
Why the scores are in negative for T score, for example?
Because if you extrapolate the standard deviation, so it's a bell-shaped curve, and whatever to the left of that graph is calculated to get the T-score. So if it is in the standard deviation that is normal, there could be some certain amount of osteoporosis in elderly. So up to minus 1 is fine. But if you go beyond that, then that is more suggestive of osteopenia or osteoporosis.
If a gentleman's score comes as 0.5, how will you explain to him?
We can tell him that he is at risk for moving into osteopenia. We can request him to improve his exercise tolerance. Then also we can prescribe him vitamin D and calcium, and we can request him to take calcium-rich food.
It's 0.5, not minus 0.5.
Oh, sorry. If it is 0.5, he has got adequate bone mineral density, so it should be fine.
Okay. Now, unfortunately, this gentleman, as you may expect with high PSA, has got multiple bone mets, and it's not a super scan in the bone scan. So how are you going to help him with his bone management? Leave the hormone management that is managed.
Yeah. So according to the EAU guidelines for patients before starting patients on ADT, it is advisable that, along with the ADT, the patient should be prescribed vitamin D and calcium. They should be given advice regarding how to improve their bone health by increasing the dietary amount of food products which are rich in calcium, like dairy products. And also we have to advise them to increase their exercise, like more up to at least up to, if tolerable, at least up to moderate exercise is advisable. So yeah, these are the things I know.
Any bone protective agents you are aware of?
There are like solid bisphosphonates or rank ligand inhibitors. Usually we give it for patients at risk of osteoporosis or osteopenia, and also for sometimes when there is bone pain. For example, bisphosphonate, what we give is zoledronic acid as 3 milligram intravenous infusion every 3 to 4 weeks. There are some contraindications like osteonecrosis of the jaw, or the patient is in renal failure, we cannot give. One of the things that we have to make sure is that the patient should be well hydrated before giving zoledronic acid. Zoledronic acid is a bisphosphonate. The other bisphosphonates which are not commonly used are the pamidronic acid and alendronic acid. Another class of agents that we can give is the rank ligand inhibitors. It is the receptor of kappa ligand inhibitor. The example is denosumab, and this is also now accepted for the treatment of the bone metastasis. The advantage of denosumab over zoledronic acid is that both of them will prevent skeletal related events. However, denosumab has also shown to improve the survival as well. Yeah.
Okay. He developed after a month or two significant pain in relation to his metastatic sites, especially the low back. No signs of any spinal cord compression. It's just the bone pain. How you can help him with for the bone pain?
So for the bone pain, there are options of radiotherapy or using the newer radio emitters. So regarding the radiotherapy, mostly what we give is the external beam radiotherapy to the affected bone area. The other methods that we can give are the radio emitters. Previously, what we used was gamma emitters like strontium. However, there is a recent innovation with radium 223. It is an alpha emitter, so it is used in bone mets and visceral mets as well. The good thing about radium 223, it is based on Alsimca trial. It has also shown that unlike the other gamma emitters, the alpha emitters can improve the bone health, and also it can improve the survival.
Okay, so how long the radium is given, and what is the advantage of giving radium?
I don't know how long it is given, but the advantage is that because it is a alpha emitter, the radiation side effects are less, and also it is better tolerated, and 3, it can improve the overall survival.
Okay, good. Done very well. How do you think you did?
There are gaps of knowledge. I have to go back and I had to practice more. That's evident.
Yeah,
But
I think there is no real gaps in the knowledge. You got very solid foundation. It's just how we can bring it out in much more comfort. That's the thing. The examiner should have the feeling that you are bringing the answers with comfort and confidence. Okay, there should not be any slight doubt, which I can even feel just by hearing you. So just blash it out and be very confident. That's very important. Preparation for bone scan, those things are very good. The bone scan, the issue is the technician should be good enough to emit the waves more than 100 and also less than 250, because if it is more than 250 it's not good for the body. If it is less than 100 it will be fully absorbed. It's a gamma ray, so it will be fully absorbed, and then the isotope counter will count the isotopes which is coming. Usually it's 150 to 200 is the emission range. The way by which you can identify or differentiate a fracture site from a metastatic site is by using the spectrometer. So that's why we are using a kind of a CT scan spectrometer in the places of the doubt, so that many a times we can find there is some accumulation in the rib, but when you do a CT scan to cover that area, it will show a old fracture or healed fracture. Even with this, it's quite difficult to differentiate from Paget's disease. That's why the history is important. Sometimes a simple X-ray will differentiate about the Paget disease findings and even the fracture. Understanding the values, you have to understand like the normal distribution curve. So as you said, it's a bell-shaped curve. The peak of the normal distribution curve is taken as 0. So anything on the right is like 0.51, 1.52. They're all normal. Anything on the left is on the lower side of the spectrum. So there up to -1, it is given as normal. -1 to -2.5 given as osteopenia. Lesser than -2.5 is considered as osteoporosis. So that's why if you understand it as a bell-shaped curve, you can understand as far left the patient as the value, it is not good for the bone health. And so if it is on the right side of the -1 vertical line, it's good health. Okay. I'm sure you should be able to draw this when the examiner is discussing. It's nice to draw whenever possible. Okay.
Sure.
Good. Can we go for the next scenario?
Yeah, you asked, sorry, can I ask one thing?
Yeah.
You asked what will be your advice for a standard deviation of 0.5?
0.5 is normal. So
Normal,
anything above 0.1 will be on the right side, isn't it? The curves, the normal distribution curve, the peak of the normal distribution curve is 0. And on the left side, we have like -1, -2.5. So anything on the right side of -1, including 0, 0.5, everything is normal. So they're all good. Okay.
Yeah, perfect.
And the T-score is, and the few questions which may be asked is like why we are selecting wrist, ankle, or a specific vertebra. Again, it's because of standardization, so that we are feeding the spectrometer the normal bone density into that, so that we get the normal pattern in the population, and we are comparing the particular patient's bone density with the normal population. If you compare age by age, it is Z score. If you compare with a standard like a 30-year-old white female, something like that, that is T score. Okay,
Oh,
it's more of a
okay.
comparison. It's not really that patient's absorptiometry. It's a comparison with the general population.
Okay, perfect.
Okay,
That's great. Thanks so much for that.
good. Can we go for the next scenario?
Yes, please.
Okay. You have a patient who requires investigation to evaluate vesicoureteric reflex. It's a 13-year-old young female, recurrent UTI, ultrasound showed left-sided hydroureteronephrosis. What is your investigation of choice?
It is a voiding cystourethrogram.
Okay, how will you do that?
So it is done in X-ray department. I would explain to the patient that this is done with with antibiotic cover and with X-ray. So it is done by passing urethral catheter with local anesthetic jelly into the bladder, and then the contrast is injected into the bladder. The amount of contrast is estimated from the functional capacity of the patient, and then the X-rays. The catheter is removed, and the patient is asked to void while the dynamic scanning is taken to see if there is any vesicoureteric reflux.
How will you calculate the functional bladder capacity of this girl, 13-year-old?
So the functional capacity is ideally calculated from the bladder diary. I would estimate that from the bladder diary of this patient. However, an estimate can be calculated. Well, she's already older than 12, so I will use the bladder diary.
Okay. So you are injecting contrast, and how will you instruct her? How are you going to do the procedure?
So I would explain to her that the procedure will be done. She will have a urethral catheterization while in supine position, and then the catheter will be removed, and then she will need to void in front of the X-ray that will take continuous image to see if there's any reflux.
Okay. Is there any way you can do this in using radioactive tracers?
Yes, indirect Mark III renocystogram can be done, in which radioactive tracer is given intravenously without furosemide, and then the cystogram phase is taken, and then the dynamic images are taken when the patient is voiding.
Why it is known as indirect Mach 3? Why indirect?
It is indirect because the Mark III is allowed to get into the bladder after a period of time to outline the bladder, and then the voiding phase is taken, which causes reflux back into the kidney.
Okay. We are a bit worried about some scars in the left kidney, of course, due to vesicoureteric reflex. To evaluate the scars, which is the best investigation you have?
The best investigation is a technetium 99 labeled diamacatosuccinic acid radionuclide scanning. It is a static radionuclide scanning of the kidney. It works by the fact that diamacatosuccinic acid is completely absorbed by the renal tubules. It is not secreted. It is not filtered nor secreted by the tubules. And so a static image is taken about 2 to 3 hours after injection of the contracts, and this shows areas of scarring.
Okay, so how will you differentiate the scarred area from normal area, and how will you calculate the function?
So the region of interest is circled on the image. The area of scar formation will show as reduced uptake or no uptake of the radionuclide agent,
And then this is used to calculate the split renal function.
What may be the radiation exposure during DMSA scan?
DMSA scan radiation exposure is about 1 millisievert.
Okay, how it compares with, say, CT scan or normal background exposure?
The normal yearly background exposure in the UK is about 2 to 3 millisieverts, so which means the DMSA scan is normal background exposure of about 3 to 4 months. Compared to CT scan, that is about a tenth of what may be exposed to when a CT scan is done.
How this DMSA scan differs from, say, MAC3 renogram?
DMSA scan is a static radionuclide imaging, and while MAC3 is a dynamic scanning. DMSA scan is basically to assess the state of the renal tubules, area of scarring, area of inflammation, but it doesn't tell us if there's any obstruction, whereas MAC3 can tell us area of obstruction. DMSA scan is better for split function because it gives a clearer picture compared to MAC3.
What do you mean by clearer picture?
Because it is a static image. When a picture is taken, it shows the state of renal tubules better than MAC3.
Okay, what is the use of MAC3 renogram in normal urology practice?
So it can be used to determine the split renal function, to determine the level of obstruction if there is an obstruction, to determine if there's an obstruction in the kidney, and then it also helps to determine the level of obstruction, and it can also be used as indirect test for vesicoureteric reflux.
Okay, say for example, in a patient you need to evaluate ureteric drainage. You are performing MAC3. How will you prepare the patient?
So I would explain to the patient that this is done in a nuclear imaging department, and it will involve the insertion of cannula with injection of radionuclide agent, and then furosemide injection. I would tell the patient to come in well hydrated and to empty the bladder prior to the procedure and to remove any metallic object on the body. And then I will explain to the patient the procedure takes about 30 to 40 minutes to complete.
Okay. Is there any role for diuretics in MAC3 renogram?
Yes, the diuretics is useful in MAC3 renogram. It helps to determine if there's obstruction of the system or not. So traditionally, the diuretics is given 20 minutes after the injection of radionuclide scanning, but nowadays it's being given about 15 minutes per hour because it's believed the diuretics effect peaks at 20 minutes.
Okay. And if you are doing a MAC3 renogram, how will you get the report? How will you read the report?
So the MAC3 renogram, the images on the computer will show the region of interest at different time intervals, and then there will be a activity time curve as well, and calculation of the split function. So on the region of interest, one can see if there is a prompt uptake, prompt drainage. Ideally, one should be able to see the bladder and have a post-drainage film as well to see if there's any obstruction. And then on the activity time interval, one will be able to compare the function in the kidney and see if there's any graphical representation of obstruction.
Okay, so how will you get the report of obstruction? How will you interpret?
So the report of obstruction will show the differential the split renal function will tell us if one kidney is not working properly. And then on the region of interest images, there will be accumulation of the radionuclide agent in the collecting or the pelvis or the ureter, even after drainage.
Okay, so it will then for the same patient, if you have to do the indirect micturating cystourethrogram, how will you convert the same investigation?
So for indirect micturating cystoretrogram, I would ensure the radionuclide agent gets to the bladder for the cystogram, and then ask the patient to pass urine in front of the camera to see if there is any reflux into the back into the kidney.
Okay, good. We'll stop there. How do you think you did?
Well, I think it was fine. I mean, like other
Good.
people, just more practices and all that.
Yeah. There is one more question I thought of asking in the end, which is like how will you calculate EGFR or glomerular filtration rate using these traces? So just have a
Yes.
read about those topic. It may be asked in the end. It's not that much used
Yeah.
in the day-to-day practice, so I just pushed it to the end.
Yeah.
The reason we are using the term indirect micturating cystourethrogram is in the MAC3 studies, we are not instilling the MAC3 radioisotope via a urethral catheter into the bladder. So the patient's kidney filters the MAC3 isotope and it accumulates in the bladder. And once it's nicely accumulating in the bladder, you should be confident that there is no traces in the ureter or in the upper tract. And then you can use that indirect method of accumulated contrast for micturating cystourethrogram. That's why the term is indirect. While the first thing what you said is the contrast based micturating cystourethrogram, where we are directly injecting the contrast into the bladder. Okay.
Yes.
So be confident why it is known as indirect micturating cystourethrogram. You should be very careful in that because if the site of interest has got tracer accumulation in the ureter and if there is stasis of tracer in the kidneys, then you can't do indirect micturating cystourethrogram because there is already a tracer, and if the patient voids and you can't differentiate whether it's a reflex or it's an undrained tracer. Okay.
Yes.
Good. And so you should be able to bring in the diuretic yourself rather than somebody asking what is the role for diuretic. So whenever you say MAC3, just bring in the diuretic, explain why you are using the furosemide, and your timings are correct. The commonly used is F minus 20. The reason why it is used very historically is you are giving a tracer. If the tracer shows excellent filtration, excellent drainage, sometime before 20 minutes both the kidneys will drain and you may not need any diuretic. But if there is any stasis, by giving the diuretic you are further challenging the kidney because more amount of urine is produced. Say if there is an obstruction, if there is less amount of urine produced, you may not be able to demonstrate the obstruction. If more urine produced, you can demonstrate the obstruction more easily. So that's why it is given as F minus 20, which is a challenge to the kidney. And since more urine produced against the fixed size of the obstruction, you can easily demonstrate. So F minus 20 brings in even subclinical PUG obstruction, for example. The other thing is once you did a F minus 20 Mach 3, if you are doing say pyeloplasty and if you are arranging a follow-up, you should make sure you are doing the same F minus 20 so that you can compare like for like. Okay.
Yes.
So you can discuss little bit on the role of diuretic and timing of diuretic also. And when you're explaining the interpretation of the result, obviously in the exam they may give you some results, so you can explain about the traces. So there are 3 curves, one for right kidney, one for left kidney, one for the bladder, and that will demonstrate whether there is a decrease in the peak of the tracer and also the prolonged phase of obstruction and slow drainage, or sometimes if it is completely blocked, there won't be any drainage, the tracer will just go up. Okay. And
Yes.
you know the O'Reilly curves, and you should be able to, you should bring out those things. Okay. The prompting is not very good sign. If examiner prompts and asks you about the types of curves and brings out the answer, still you'll get good mark. But if you can bring yourself, that creates the examiner, okay, he is a complete urologist on his own, he doesn't need somebody to see whether he has the knowledge or not. Okay. I was expecting you to bring out the curves, what is the names, everything. You should be able to bash out. Okay, so practice like that. Good. Can we go for the next scenarios?
I think we are just three
Uh,
online.
do you guys want to do one more scenario if you want?
Yeah.
Well, I don't mind.
Okay, your time starts now. You are doing a flexible cystoscopy in a hematuria clinic, and one of a newly joined SPR is asking you why we are using flexible cystoscopy rather than a rigid cystoscopy, and what is the advantage of it. How will you explain that?
So I would explain that the flexible cystoscopy as against rigid is flexible is like passing a catheter. It can be done under local anesthetic jelly, and the fact that it's flexible, we're able to manipulate the tip of the camera to look to have a complete view of the bladder. The only drawback to when compared to rigid is the image is not as great as compared to the ones from rigid cystoscopy.
Okay, why the image is not great compared to rigid cystoscopy?
Because the flexible cystoscopy is has come in size. The one I use in my practice is 16.5 French gate size, and so it is not as it has got fiber optic fibers within it, and a small working channel compared to a rigid cystoscopy. So the flow of water is not good as compared to rigid cystoscopy. This does limit the image.
Okay. And in your practice, you are using a reusable flexible cystoscopy, which needs sterilization between the patients. Do you aware of any other newer modalities in this aspect?
Yes, I'm aware of disposable flexible cystoscopy, which I've started using in my practice. There are different companies making that. The advantage of this is that it does not require sterilization in between procedure, and so there is a reduced risk of infection transmission amongst the patients, and then they are mostly digital scopes with good picture quality.
Okay, so what is the main advantage of this from the cost point of view? Is it advantageous and why they are introduced?
The advantage is the fact that overall it is cost effective because the cost of sterilization, payment for staff, sterilizing equipment and all that are put into consideration. The disposable scopes are eventually proved to be cost effective.
What is the difference from the technology point of view between the sterilizable, reusable, flexible stethoscope which we use in general and these single-use scopes? What is the difference in technology?
The single-use scope are digital scopes, while the reusable flexible cystoscopes are fiber optic scopes. With the digital scope, the chip is at the tip of the scope, and it transmits the image to the monitor, which has better quality compared to the fiber optic scopes.
What other things which you may be doing in reusable scopes but not in the digital scopes? Anything specific?
I'm not sure.
Okay, and because of the being digital, ergonomically, is there any difference for the surgeon?
Well, for the surgeon, no. Well, the fact that they are digital, they are usually not as flexible at the tip compared to the fiber optic. Otherwise, there's no difference.
Okay. Is this disposable single-use scopes available in the other areas? What other areas in urology?
So there is a disposable flexible ureterorhinoscopes, which is used for treatment of stones in the kidney, or even treatment of small lesions in the renal pelvis.
Okay, so what is the advantage of the digital single-use ureterorhinoscopies?
So the advantage again is due to the fact that they are high definition based on the presence of chip at the tip, which transmits a quality image to the monitor. They are also light in the sense that they do not require addition of a camera head, and there is no need for external lighting source. Everything has been packaged together into a single instrument. The only drawback is they are not as they are wider than the flexible retrorhinoscope, the fiber optic, and so they are not the tip deflection is not as great as in flexible fiber optic.
How do the single-use flexible ureteroscopes size compares to the reusable one?
The size at the tip is about 9.5 French gauge, whereas the reusable ranges from 5.4 to about 9. The one I use in my practice is 5.4.
What is the smallest or thinnest single-use ureteroscope available? Any idea?
I have no idea.
Okay. Now, your management is coming out with a tabletop review. The reason is you had 4 reusable flexible ureteroscopes, but unfortunately within past 3 months 2 of them was broken. So the main idea they are asking you is why this happens, how to prevent this, and will a single use ureteroscope is a solution.
So for reusable ureteroscope, they are prone to damage when the laser fiber or other instruments like a basket are used. They are passed with the tip deflected, and so ideally they require leak test prior to use and after use. And if this is picked, this routinely must be adequately repaired. The other aspect that damages reusable is the handling of the instruments when it's being transported for sterilization. These are not issues with disposable.
Okay, so coming to the economics, if how long or how many patients if you use a reusable flexible ureteroscope you think it's good? Is there any cutoff, any studies on that?
I'm aware of a study. I'm not sure of the exact number.
Okay, so in your practice, how many cases a single flexible ureteroscope comes for you? Any idea?
It's about 20 something. I'm not sure.
Okay, good. And what is the mechanism by which the light and image transferred in a semi-rigid ureteroscopy?
So the semi-rigid retroscopy has similar mechanism as a flexible fiber optic. So it's basically fiber optic fibers encased in a semi-rigid metallic sheath. And the images the light is transmitted by total internal reflection, and the images are transmitted by the fibers. They are arranged in order, so such that the image at the tip of the fiber is what is picked up at the eyepiece of the telescope.
Okay, so what is the difference between, say, rigid cystoscope light transmission, light and image transmission?
The rigid cystoscope uses Hopkins mechanism, in which case there is the rod. There is glass rod lenses separated by thin layers of air, which are encased in metallic sheath, and this helps in transmission of light and image.
Okay, is there any improvement in the Hopkins rod lens system compared to say 30-40 years back? Do you know any improvements?
So the initial thing was a short glass rod separated by large gaps of air lenses, but this has been improved to be large glass rods separated by thin layers of air lenses.
Okay, So in a rigid cystoscope, for example, or a semirigid erythroscope, the image is taken from the tip of the semirigid erythroscope to your monitor and light transmitted in the opposite direction. What is the difference between the light transmission? What is the difference between the light transmission and image transmission?
The difference between the light transmission and image is that light transmission doesn't have to be a coherent transmission, whereas image transmission must be coherent. In which case, all the images at the tip must be transmitted back to the monitor for proper view, whereas light doesn't have to be coherent.
Yeah, good. So I will complete the last answer by appropriate coherent spatial orientation so that the 12 o'clock image is in the monitor at 12 o'clock. But for light, it's a white light or any color light, so there is no need for fibers to be parallel to each other. Okay.
Yeah.
Good. Well done. I have no concerns. I will be happy if you are a little bit more stronger from the digital front point of view, because even the reusable digital erythroscopes has the same principle. You are quite good in chip on the tip technology that results in bulky tape and inability to have appropriate flexion in the tip. But there are few other things like digital scopes doesn't require white balance. Digital scopes will autofocus by itself, so you don't have to do any focusing. And since we are not attaching an external camera head, it's quite good ergonomically for the surgeon. The weight in the hand of the surgeon will be less, so if he has to do a flexible ureteroscopy for an hour and a half or 2 hours, it's very user friendly for the surgeon. And you should be able to give a little bit more information on how are you going to use the single-use flexible ureteroscopes in the practice. This is more of a management question, but as you know, in technology you can get some management related questions. So for example, if you have the single-use digital cystoscopes, you can use them in the clinic to remove the JJ stent. Patient attends for the clinic for the review, they check x-ray is normal. Instead of listing the patient for the stent removal, you can just use a digital scope. It can be taken anywhere with a small monitor which is almost the size of an iPad. It's very useful if a patient comes with a urinary retention in A&E or in the surgical assessment unit, where you can take the scope to do a camera test, not only to assess the hematuria, which can be done even later, mainly for placing a catheter if there is a stricture, if there is a difficulty in placing the guide wire based catheter placement. But in other words, you need to really book a slot in the endoscopy room, which may be already having a session running. So there are some advantages of these single-use scopes, which can be widely used in various clinical floors compared to only the endoscopy rooms. The cost is the issue. As you correctly said, the reusable flexible ureteroscopes, if it lasts for 15 to 20 patients, that's a very good score. But if somebody is very careful, they can use it for even 100-150 patients, as long as they take all the meticulous care. As you said, leak test before and after, making sure the laser fiber is not passed with the tip in the flexed position, using only the sensor guide wires, not the PTFE normal guide wires, cheap guide wires, and just taking care of it both intraoperatively and also what is happening in the sterilization room. The thinnest single-use flexible ureteroscopy is 7.5 French. That is the thinnest available as of today. The commonly used is a 9.3 French, which you already said. Yeah, that's the main thing to add. This is a very hot topic, so there is a possibility that if the exams are the questions are usually revised every third year, every fourth year. So whenever the revision happens, you will find some new questions popping up. So it's nice to know something very, very hot and up to date. You don't know, the questions may be revised a month or two, isn't it?
Yeah.
Good. Any questions?
Thank you very much.
Welcome.
Yeah, I wanted to ask about the flexible the flexible ureteroscope. You said the smallest is 7.5.
In disposable.
Now, the disposable. What of the reusable?
reusable we can have, as you said, reusable we have even up to 6 French. It depends upon how much you are going to spend. If
No,
you
I mean the HD, the digital at the tip, the
yeah
chip at the tip.
yeah, so reusable is divided into fiber optic and digital, so use the correct terms. Okay, for fiber optic the size could go up to 6 French. For digital the size again stays like 8 French or 9 French. So all the digital are in the region of 9 French with the bulky tip and difficulty in deflection, but in the single use it has just come down to 7.5. It's a very new product, only used in 4 or 5 centers in the world, very early stage, so obviously it will be very costly. But this 7.5 French is a very big move that results in very good irrigation. You can use the 7.5 French single use ureteroscope with an access sheath which is like 10/12 French access sheath, while in if you want to use a 9 French single use you need to have an access sheath which is much bigger, like 12/14 or even bigger access sheath. So it will make a big change, but that's for future.
Then you mentioned about the study on the number of use for reusable ureteroendoscope.
Yeah, the main outcomes from the study are the average use of the multiple use flexible ureteroendoscopy normal, that fiber optic, is around 15 to 18. That is the study. So if you are able to use your fiber optic ureteroscopes for say 18 to 20 patients per use, that's good. So it's important for you to have this data. So when you're doing a tabletop review with one of your managers, you should be able to say this scope worked for 20, which is the world average. So we have done a good job. So we are doing good. Let us buy some more flexible ureteroendoscopes and maintain it. The use of digital is very good for TCC diagnosis. So if you have a high volume of upper tract TCC, that's very handy to use it very selectively, not routinely for stones as of now.
Thank you very much.
Very good. If there are no further questions, we will conclude today's session. Tomorrow we will discuss on emergencies. Wishing you a very nice, happy Sunday.